Okay, so good morning everyone and welcome to our co-production webinars. We're really grateful to be joined today by Terry Gavin-Jones, midwife and author working in co-production and engagement, and is come to present today and to talk with us about co-producing and engaging with underserved communities. Unfortunately, our colleague Emma Ponsonby has unable to attend today and because she's not feeling very well, so we do wish her all the best and hope that she gets better soon, and hopefully we will be catching up with her on another webinar later in the year. Please do feel free to put questions into the chat box. We will be taking questions afterwards and going through those, so feel free to add them as you wish. So without any further ado, I'm going to stop sharing and I'm going to hand you over to Terry. Welcome, Terry.
Thank you, Rachel. Well, good morning, everybody. If you're not on mute, would you mind putting yourselves on mute? That would be amazing. Thank you so much. And welcome this morning. I'm in Suffolk. I don't know what it's like for you, but it's a gloriously sunny day. So excited to be here. My name's Terry Gavin-Jones. I am the Senior Clinical Lead for Suffolk and North East Essex LMNS. That's a local maternity and neonatal system, if you don't know, across the ICB footprint. So we're full of acronyms, aren't we? And I'm here to talk about one part of my work stream, and obviously the work stream is massive in maternity, but one part of it is around co-production. So I'm just going to take you through the journey that I've had with co-production, focusing on some particular communities, and I'm going to share some slides with you. Really got to try and not do death by PowerPoint. So feel free to ask questions, pop them in the chat, or shout. Obviously, once I've started to share the slides, it's a bit like talking to a dark room, really, isn't it? So I can't see any of you. Let me just see. Have they come up though? I can see Rachel. So would you just nod if that slide deck has come up? Lovely, thank you. So, as I said, I work in Suffolk and North East Essex, and I've been working for the last few years on co-production, and in particular, the maternity equity background. So for many of you, it will be very, very familiar when we're talking about health inequalities, but just as some background, we were asked by NHS England a couple of years ago to submit and produce a 5-year equity plan in partnership with the community. So I led on that, and it was an amazing piece of work from my learning point of view, and it has taught me a great deal. What we didn't want to do, and I'm sure what no system wants to do, is produce an equity plan for the next 5 years and it be a tick box, really. It's a massive document. It's RAG rated, as everything in the NHS is, and we wanted to make it particularly meaningful. So for me, submitting the equity plan was all about well, so what? What does that mean? If we've scoped it, how can we then make it meaningful? That, of course, comes off the back of all of the statistics that we all know about. So there are several national reports describing health inequalities within maternity. We know that Black women are 4 times more likely to die during the perinatal period than white women. We know that Asian women are 2 times more likely to die. And these are some stark statistics that I'm sure you're all familiar with. And this is a complex landscape. We by no means think that an equity plan will solve some of these issues, but it certainly started to help us unpick some of it. We also looked at the Embrace reports. We know that if you live in a least deprived area and you are white, your chances of experiencing a stillbirth are 2.78. If you are black and live in a most deprived area, it's 8.1. So again, these are the figures and the statistics that drive us and drive all of us nationally to do better, to make the effort. For us, it was about how we're going to do things differently. And in maternity, I've been a midwife for, it feels like 100 years. I am incredibly old and have been a midwife for most of my adult life. So for me, it felt a bit like asking the questions of how do we do this differently? How do we stop doing what we've always done? And stop trying to squeeze a square peg into a round hole. We have a maternity system that is very much a one size fits all. And that system is driven, as we all know, by capacity and funding and all of the constraints and restrictions around the NHS. But it isn't serving the purpose when we're talking about health inequalities and those stark statistics that we know. So we had to look at it in a different way. I created to start a maternity equity forum. And that forum is very much driven by VCSE leaders. And a lot of the stuff that we do in maternity historically has been led by us in health. But I very much wanted it to be community leaders who drove this forward. So I've got 55 community leaders in our maternity equity forum. They don't all come to every meeting because we meet once a month, but we understood that the direction really needed to come from them. And then what we did last year was we amazingly found that we had some money, some underspend in our particular budget. And we were trying to, again, look at the equity forum and our equity plan and think, where will it make the most difference? How can we change things? We know we've got a landscape of a national picture of a shortage of midwives. And it does feel like we ask midwives to do more and more and more with less and less and less, if I'm honest. And the results are not getting any better, if I'm honest. So we went out to the community and we went to our VCSE partners and we said, if we gave you some money, what could we do? How could we work together in a way that we haven't done this before? So they came back and they made suggestions, and we had enough money to fund 6 of them. And those 6 are the ones that I'm going to talk a bit about today. So they're African families in the UK based in Colchester. There's an organisation called Phoebe, which is based in central Ipswich. We have Petals, which is a counselling, baby loss and bereavement service. Ipswich Community Media, Survivors in Transition, and YES is called the Youth Inquiry Service. So those were all the people that came forward and said, actually, we could work with you in partnership for what you want to do. I was looking for a social prescribing model. And for me, it's become really clear that there are other aspects of the NHS that do things much differently to maternity. When we look at kind of the care of the elderly and the neighbourhood teams, what I was finding that they were very much using a social prescribing model. They had the person at the centre and all of the services would wrap around them. End of life care was one of those that really illustrated that to me. And we do a bit of that in maternity, but not so much, and certainly not in our area. So I wanted that social prescribing model where we use the voluntary and community sector much more effectively than we do currently. I think historically we've had a bit of a attitude in maternity that only a midwife can do something. We have to do it ourselves, and we can't do it all ourselves, and certainly we don't have the skills sometimes to do it all ourselves. So I reached out to the groups and I started to meet with them. And one of those organisations, African Families in the UK, I asked to go and meet with their leader. She's a fantastic woman called Rachel Walton. And I went to meet her for the first time. And I said to her, can I come and survey your community? Can I come and ask them what we could do differently in maternity? Can I ask them questions so that it will drive us all forward? And she looked at me and she said, no, you can't come and survey my women. She said, you know already the answers to any surveys. Our women are dying. Stop surveying the women and start doing something. And that was a moment for me where I thought, actually, I have to take my NHS hat off and start to look at this very differently. So Rachel Walton told me a story about TAPS, which is a bit random, but I kind of like random. And she was working for a charity out in Nairobi, and they were working in a small village. And within this village, there was no fresh running water for 5 kilometres. And every day the women got up and they went to get the fresh water very, very early in the morning. They walked to get it and they brought the water back. And they did this over and over again every single day. Now, the charity working with them thought that this was a terrible thing and decided that they were going to install taps on the edge of the village so that they didn't have to walk very far and fresh running water was there for them. So they did all of the work. They put lots and lots of funding into it. They installed the taps. And for the first couple of days, the women went to the taps and used the taps. But after a week or so, they noticed that the women were walking past the taps and continued on 5K to the old taps to get their water. And when the leader of the charity said, "Why are you not using the taps?" what the community told him was that actually you didn't ask us. You didn't ask us if we wanted taps on the edge of the village. And when we get up in the mornings, when the taps are on the edge of the village, what happens is that our small children and our big children, and sometimes our men folk, they come with us and they gather around the taps. But what we were finding previously is that 5K walk was just us and our babies, maybe, and we had a chance to talk as a community, as a population, as a group of females. We really, really valued that time to talk to each other and the walk there and the walk back. So before you do anything, you need to ask us. And that has really stayed with me when we are co-producing any service in maternity. Quite often, we don't do the work of let's ask what happens. The other thing that Rachel taught me, and she's taught me many things over the last 2 years, is that I know nothing, pretty much. And one of the other stories that I had is that I wanted to create some personalised care and support plans because we're really keen on choice and personalisation in maternity, as everybody is. And we created some visual icons. And we made a lovely, we call them a PCSP, personalised choice and support plan. And I said to Rachel, can you take it to your community? Can you ask them what their thoughts are on these visual icons that we could use? And she said, yeah, all right, I'll take it. And anyway, the next meeting I had with her, she came back and she said, it was a disaster. I'm going to tell you it was a disaster. The women in the group couldn't understand why you had pictures of birthing balls. They just didn't understand why they would use a birth ball because they're from a community where they always stand up and they sway and they dance and what use would a birth ball be? They didn't understand the music and the massage and all of the icons that you put on there. And she said, you've really come at this again with a very NHS model. And she started to talk to me about traditional birth wisdom. And what Rachel said is that actually birth plans and being taught how to give birth in our community is all very well and good. But what we know is that when somebody in our community becomes pregnant, the information about birth is passed, and it's passed down from the mothers and the grandmothers. She said there is some traditional birth wisdom that they always pass on to each other. And then she looked at me and she said, as a midwife, we absolutely respect your knowledge and your wisdom. She said, and we will take some advice from you, but only if that advice is more knowledgeable and wiser than the grandmothers. And then she looked at me and said, you are not wiser than the grandmothers. So that was me told. I understood that actually we have to revere the traditional birth wisdom. So on that basis, I merged with African families in the UK. I wrote an email to my boss and said, if you need me, this is where I'm going to be. Rachel said to me, come and work with the families, but you can't survey them. You can't give them pieces of paper. Don't turn it into a classroom. You need to eat with our community. You need to walk with our community. And by doing that, they will tell you things. They will tell you stories. So what they did is they worked up 14 specific community ambassadors for us with the money that we gave them from all walks of life in the community. And I meet with them regularly, usually once a month. We have food, there's usually music. And I do a bit of, this is what maternity is, but that's probably only 10%. And they do much more about the education and the cultural wisdom that I need to take back to my maternity colleagues. So we have all kinds of topics. And on this day, I was talking basically about labour and you can see a cervical dilatation. I was telling them all about how the cervix dilates, which was a very small part of it. And they tell me their stories and their knowledge. It was a great sharing day. There were 31 people in that room that day, and each community ambassador then feels that they can go out and speak a little bit more confidently about maternity. We might talk about triage and the pathway through triage. We might talk about when to call the hospital if you don't feel your baby moving. We've talked about all kinds of things, vitamin D, folic acid, all of the things that I want them to know about as a midwife. And then they tell me all of the stuff that I need to know about as somebody who's a cultural ambassador. Some of the stuff that they do is working in advocacy. They do some translations for us. They explain the maternity pathway. It's a real community-based model and avoids isolation, increases their emotional well-being. So those are some of their stats. They provide us with stats. And again, a very NHSy model with the stats, but I am absolutely convinced that we need to embed this substantively in our maternity model. So I'm always looking for funding. So I'm keen to get those stats from them so that we can get our funding together. Ipswich have the Phoebe organisation, and they work with migrant communities. Often these are people with no recourse to public funds or asylum seekers, people seeking sanctuary. It's a very female-based organisation, and they often work with women who come to them who are dependent on their spouses, who are often their abusers. They are financially not in a good place, and many of them are homeless. So Phoebe is another great organisation, and I meet with them monthly as well. The way that Phoebe have organised it is that they have created a grandmother group, and it was really interesting going to another community who told me exactly the same thing as the African families over in Colchester had told me. They said to us, the grandmother is the boss, essentially. She is revered. And again, we are going to listen to you as a midwife, but if the grandmother says something different, that's going to be a problem. Now, the way that we have addressed this is that what they did is set up a grandmothers group. So they currently have around 15 grandmothers. You can see some of them there. I meet with them on a Monday, once a month, and they are a feisty bunch of women. Most are in the 70s, and most of them have come most of them were midwives, interestingly, in their home countries, and have very, very strong views on maternity and women's rights and lots of things. We have some amazing conversations, and they tell me lots. I've learned all about birth herbs in labour. So what I didn't know, and as I said, I've been a midwife for 100 years, but I did not know that women from this community, as they go into labour, take some herbs. I can't get to the bottom of what's in the herbs because they won't tell me, and lots of them don't know either, but the herbs are sent from their country. And as a clinician, that kind of makes me a little bit sweaty when somebody tells me that. But this has been going on for years and years and years. And what I've learned is that I have no rights to be judging something that isn't harmful, but is culturally very important to this community. So the grandmothers are amazing. We've talked a lot about different birth practices over the couple of years that I've been working with them. And again, they go then out into the community and they support all of the pregnant people and the population. They've got a peer-to-peer support group, which works really well, and they support postnatally as well. And some of the other work they've done is around maternal mental health awareness in Phoebe. We've worked with an Afghan refugee hotel in Colchester, and that was really interesting as well to look at some of the cultural wisdom and beliefs that needed to be respected as we worked with this community. And the Youth Inquiry Service are heavily embedded here, so we work with them to work with this particular group of people. Ipswich Community Media is another organisation that run English classes for groups of people, and we've embedded maternity into them, so they're one of our partners. So they invite the midwives along, and they'll do a session about the different kinds of language, because when we talk about language, we just don't mean different language. The obstetric language is very, very different. So the words we use to describe things, and they've done a lot of myth debunking as well, which has been massively useful to us. So they're one of our partners, and they're working really solidly with a massive community for us. And then one of the other communities is, one of the other organisations is Survivors in Transition, and they support men and women who've experienced sexual abuse in childhood. And these are survivors of sexual violence. And we know that pregnancy and childbirth is often a very triggering time for people who've experienced this. So Survivors in Transition we've partnered with them, and they are extending their offer right across our ICB footprint. They are absolute experts in supporting people through this. So we have a real mechanism now if somebody comes across somebody who needs extra support to work with them, and we're really grateful for their expertise. And then we're working with the Outhouse in Colchester and raising awareness within the LGBTQ+ community. We had our first transgender couple come through Colchester Hospital, and I was really interested to hear their experiences of what it was like as a transgender man being pregnant and working that journey through maternity. I went out and did some filming with them and gained some feedback, and they had a lot to say. A lot of it was actually really, really good. And they've helped us to improve our services, and especially around our language and our offer to that community. So once every quarter, we bring all of these communities together, all of these partners that we've funded, and we provide a forum, and they all do a bit of an update and they learn from each other, because it's no good us funding them and then them doing stuff in isolation. So right across our footprint, they all come together, they give presentations, they talk about the effect they're making on their community. And that's a great day. They really, really value and share the learning. We also invite our maternity clinicians and partners to hear about the work they're doing. So we're sharing that across. And then more recently, we turned it into something a little bit more proactive, which is a women's health festival. And we were given a spot at First Sight, which is a very enormous art centre in Colchester. And they allowed us to hold a health festival there to celebrate all of the communities that we were working with. I've got a very small video to show you about that, so I'm just going to stop sharing that if I can. Hopefully I've stopped sharing. Have I stopped sharing that, Rachel? Can you tell me? No, of course I haven't. There we go. Okay, there we go. Let me just show you the First Sight. That should come up on your screen any minute. Can you see that? Yeah, lovely. Thank you.
I think it's just taking a moment to load.
Is it? All right, I'll just give it a moment. Yeah, it's there. Wonderful. Oh, let's go. So that was just a taste of our first Women's Health Festival. That was in March of last year. That was really, really successful, and we're hoping to do another one next year. So If anybody wants to come to that, I'll let you know. I'll just take you back to finish off the slides. They come back up so you can see them again, Rachel?
Yeah, we've got them.
Lovely, thank you. I think they've gone back to the start on mine. Whiz through these. Okay. So what I think for me to kind of finish this part is that service user feedback has been really important. And for us, we've really expanded where we get that feedback from. We obviously have our MNVP and we have a lead in each area, hugely valuable. And then we have our maternity VCSE partners that I've just described to you. We have our equity forum with many members, including Health Watch and local government and lots of charity organisations in there. And then we also have a 33-hour-a-week LM&S co-production lead. So we've got layers of service user feedback that we can rely on, and I'm calling it a maternity collaboration because that's absolutely what it is. So the last bit is really to talk about staff. We've talked about the community, but I wanted to really focus on our staff. And I wanted to ask them a series of questions. So this is a very small survey. I will say that right up front, but I wanted to get a bit of a snapshot. So I asked them a couple of questions, tricky questions, and I asked them, are you comfortable having ethnicity conversations? We all know the stark results of around ethnicity. So I wanted to find out if they were actually having those conversations. 52%, just over, were comfortable, but that left 47.5% were either uncomfortable or only sometimes comfortable. Do you discuss the risks associated with ethnicity or skin colour with all of your Black, Asian, ethnic minority people? And interestingly, 70% of the midwives I asked were either in the no or the sometimes bracket. Now, I don't for a minute believe that midwives don't want to have these conversations, but I do believe that they find them tricky. And they were telling me that they didn't want to have those conversations because they were fearful. They didn't know how to open that conversation. They were fearful of being seen as racist or culturally inappropriate. Do you believe there is racism in maternity services? Which is another question I asked them. You can see the results there. There were many more questions on the survey, but I wanted a snapshot. I wanted to understand if we were getting to the heart of, you know, this has to be something that starts at the midwifery appointment to address some of the risks that we understand. There's a lot of talk about maternity cultural awareness training, which is a fantastic thing in itself, but what I'm finding is that it's not possible to train all staff in the current climate, and then you only get the staff that are signed up to going. And this is a problem for me. We know that we have to find opportunities to have difficult conversations around ethnicity. And the staff were saying, we're not confident, we don't know how to approach it. So what I did is took it to the equity forum. And I said to the forum, how do we do this? How do we address the issue of opening up that conversation? And the forum said to me, we want our voices to be heard. We want people to understand that it's okay to ask us actually about this. Please don't be embarrassed or shy or afraid or fearful. We'd like to talk about it. So with that in mind, I commissioned a filmmaker, and we spent 7 days and 24 interviews, and we created 11 films. And the films actually are called It's Okay to Ask. We're using them not just in our system, but right across the country, actually. Not as widely as I'd like, because I think there's more to do. But we are using them, although they're maternity based, I think they can be used for all staff training. There's something that all of us can learn. So it was the community that led us to this, and they absolutely gave their voices and participated in it. So I will now show you the trailer of It's Okay to Ask. Let's just do that. Stop sharing with you. And I will just pop the trailer up so you can see that. Okay. Has that come up on your screen? Marvelous.
There's this stigma that people think, oh, I will come out as racist. I want to be politically correct. We don't mind. Ask us about our color.
Yes, of course, the same choices of breast versus bottle exist for all of us, but there are different pros and cons as to how you do it when you can't see.
She will have to make a decision about whether she eats or whether she comes to the clinic to see you.
I was nervous, I was scared, I was overwhelmed, I was excited. My sexuality, who I was married to, what my gender was at that point actually was quite irrelevant.
I think as midwives, we need to look at the person and not at the label.
I was in intensive care for 2 days. I lost.
I think what it does to professionals is make them think, I have to take complete responsibility for this.
People often find it very difficult to describe pain.
The only way you can fully understand people is by creating that human connection, isn't it?
Because if you don't ask them that question and get to understand their needs and requirements, how will you ever be able to offer them the service that's right for them?
And then they were a bit stuck. They didn't know who's going to do what role, what does that even look like?
The best thing to do is to actually just ask.
Okay, so there's 11 of those films, all on a different community, all filmed within our own communities and wider. And you are very welcome to have them. There's a whole showcase on Vimeo that I'm happy to share the link with you. It's in the slides anyway, which I will send round if you want them. I'm going to stop there because I think maybe we need some time for conversation and chat. I don't know if there are any questions, but thank you for listening. And feel free to ask questions.
Thank you so much, Terry. That was a really, really helpful presentation. I think that the first question we had was in the chat from Nina Pearson asking what evidence is there to describe the distinct contributions of deprivation and ethnicity to the inequalities in maternity outcomes, please?
What evidence? I'm just trying to look for that. So let me see. What evidence is there to describe the distinct contributions of deprivation and ethnicity to the inequalities? So if we look at the Embrace report, the evidence all sits in the Embrace report. So we know that women who live in poverty, their outcomes are much, much worse than anybody else's. We know that Black, brown and mixed ethnicity people their outcomes are much, much worse. So And again, I could put a slide up about the Embrace report, but I can put a link to the Embrace report in there. So Embrace release their statistics every 3 years. They are a national statistic reporting service. And it's very, very clear to us that deprivation and ethnicity absolutely impact on outcomes. So we do have all of that evidence. Do we want to go to hands up, or would you like me to answer some more questions?
No, I had my mic on mute. I said, Sian Piver, you've got your hand up first. Go ahead.
Hello, Terry. That was really interesting talk, and I'm really interested in those videos. So looking forward to watching those. I think it's been really quite emotive and informative. So thank you. The thing that struck me, one of your slides where you were talking about your equity forum, your maternity BCSE partners, is the 33 hours a week co-production lead that you've got. And obviously I'm going to ask the question, how did you get the funding for that?
Oh, yeah. So the funding, I don't know if you know anything about maternity funding for us. So I work in transformation. So it's non-recurrent funding. We're never substantively funded. We get transformation funds come down every year. It's a pot of money, and we are there are some national drivers. So there's some things we have to do with that money, and then the rest of it is about how we run our team. And obviously I'm clinical lead, and we have a PMO as well. And then we have a team, and we make that team up as to how we see fit, really. And we felt a co-production lead was really, really important within that team. So we've got Rachel. She's, as I say, 33 hours. it's only a year's funding, and next year we'll get another pot, and hopefully if it goes well, and I'm sure it will, then we can continue and extend that. But we've funded her out of transformation funds.
Thank you.
Thank you, Sean. Lucy Nicholson.
Hi Terry, I'm
Hi
from
Lucy.
And hi. So I think mine's similar to the funding thing. You started the presentation, which was amazing, and obviously Healthwatch supports all co-production, thinks it's a wonderful piece of work. But you started the presentation by saying you had an underspend in the budget, and I think for me that just sort of resonates with sort of embedding co-production within the NHS structure and contracting, that we are looking for these underspends and budgets, which allowed you, thankfully, to be able to look into this sort of project. I think my question is more wonderful work, but how do we get sustainable funding to produce this in order to do co-production properly? You know, we really need Rachel here full time on a 5-year contract at least to really embed the culture if you're going to really make change. So I think it was just
You're talking my language, Lucy. Really, it's been my life's work. I think it feels like my life's work. It's only been a year's work. So what happened is we had the underspend. I don't think I'll ever be saying we had an underspend again, if I'm honest. I don't think I'll ever say it. We are 159k shorter in our transformation funds this year than we were that year. So that gives you an idea. And then we've you know, all of the NHSs, we've got a 15% running cost to save as well. So this year is tight, and the year that we had this was a very unusual year. So yay for an unusual year, and we had an underspend, and that's how we managed it. I was very aware as we went into it was an underspend. So you label it as a pilot, don't you, really? And what I'm aware of is working with the third sector is they were saying to Rachel Walton in particular, she said, you fund us just enough to fail. That was her words, and that's always stuck with me. So a year is nothing. You're just getting stuck into it, and then you pull the fund in because you can't do it. So as we started it and as we rolled it out, I am really lucky because I've got a role in the ICB where I can access all kinds of people in my ICB. And the chief exec of our ICB is absolutely signed up to reducing health inequalities. He was, so I did a presentation for him, and he got me into all of the exec board meetings, and I've presented just about everywhere. They're sick of the sight of me talking about maternity, I can tell you that now. But any time that they had a board meeting, I would pop up and do some slides for them. I talked a lot about epigenetics and the fact that the way that we grow and gestate a child impacts the lifelong future of that child. And I went in with a public health message, essentially, because I think everybody sees maternity as a one-off event where you have a baby, then you leave, and that's it. But actually, if we get maternity right, if we grow a baby in the right environment, and then we birth a baby in the right environment, that actually will impact on the SEND, on the primary care, on school age. We all know this. I'm not telling you anything new. And your life chances and your health right the way through your life. So I've gone in with that message pretty strong. I've now convinced them all, and I think they've just kind of gave in, if I'm really honest, because I'm a bit like a dog with a bone. But they gave in and went, okay, yeah, you're right. And they've taken it on board, and they are going to substantively fund those 6 VCSE partners we work with and take them into the main ICB and look at them as partnerships. But it was just pure dogmatic. I think they're sick of the sight of me, if I'm honest.
Thank you, Terry. Nina, you've got your hand up next.
Hello, yes, Nina Pearson. I'm a GP and Clinical Director for Primary Care Network, and I'm Strategic Primary Care Workforce Lead for BLMK. So I want to sort of come back to this dual impact of ethnicity and cultural backgrounds and deprivation, and wanting to explore the maximising the impact of every opportunity of community engagement and seeking the views of those in the community who have knowledge and expertise, because deprivation is a big factor.
Yes.
there are many women who are heading households where, you know, they're wondering where the next meal is coming from and whether they'll be able to live in the same place next week. So the ability to engage with anything that is on offer is limited by the major stress of these things.
Yeah.
And certainly in all general practice work, you know, I now ask people, is your money all right and where are you living? Because unless you get beyond that conversation and do what you can around that, there's no chance of helping them to take really good lifestyle choices around managing their diabetes or whatever. And it's the same for maternity. So this work that's going on, listening to the community, yes, okay, but are you also doing parallel work about enabling them to access whatever is possible for them to access, and finding those resources that they need to live day to day, because some of them
Yes.
aren't.
Yeah, and I agree with you, Nina. So thank you for that question. And I think that's probably me not explaining because the time is short, although it doesn't seem short sometimes. But the community ambassadors that we've worked up in each of these groups are essentially social prescribing signposters. So although I'm talking about maternity, they will help people fill in forms, they will work on their benefits, they will help work with their housing. Often they run food banks in the same hubs, so they will be advocating for them. They will go to maternity appointments with them and GP appointments. They run a childcare service where they look after the, you know, if you've got 4 children and you're pregnant and you have to get on a bus to go to a hospital for your hospital appointment, that is a tough ask. So what they're doing is providing taxi services for people to get to the hospital should they need it, or they're looking after their children. It's a real community model. It's much more than maternity. So the maternity element of it is important, but actually it's about signposting to every other element there is. I hope that answers that.
It does, and that gives a much more vivid picture of what's been offered, because it was fairly narrow what you have described before. Yes, good, listening to the community, but actually, unless we take action and enable them to take action, then we're not going to progress forward. So that's really helpful, and being able to spread that across all providers, you know, so do midwives know that's what's happening?
Yes, they do.
You know, et cetera, so that they link in really solidly with it, rather than inadvertently giving contrary advice or contrary directions.
Yeah, agreed. And I think the comms is really important. The midwives and all healthcare professionals need to understand the partnerships that we've worked up. So as you say, they can signpost to it. But what we found is that the information coming from a trusted source within the community is much more trusted than coming from me as a midwife. So they really are ideally positioned to give that. I've focused on a couple of the organisations, but we also work with Homestar out in Tendrin, and Tendrin and Jaywick is the most top deprived area in the country, actually. So there's an enormous amount of deprivation in Tendrin, and we're working with Homestar around baby banks and signposting there. Any other questions?
I've got no one with hands up at the moment, but just a few comments in the chat. I one from Samantha saying it's amazing that you're listening to the communities and understanding their needs. I believe there is an unconscious bias in maternity and obstetric services, and I think this starts at the grassroots of initial training. If we address this during the training period, we will eliminate this. So I suppose in addition to that, I would ask, is there scope for expanding the programme into maternity training and working with the education providers?
Yeah, and that's always my aim. So I absolutely go to Teams meetings and stat training and do the same kind of updates for them. It needs to be mandatory training. It really does. There's got to be some education from the staff point of view, and you know, just an awareness really. I think yeah, there's a real lack of awareness, and there's more. I'm not suggesting that this is a complete journey, by the way. This is just the start. We've only been doing this for 18 months. We're only on the start. There's so much more to do. So it's a real evolving project, and I'm hoping that we expand.
Thank you. And one from Tote, I hope I'm saying that correctly. Thank you Terry for sharing this amazing piece of work. I'm even more pleased at how you're able to embrace and respect different cultural experiences. and see how they can play a big role to improve people's lives. Lots of thumbs up for that one as well.
Thank you.
Very much so. Has anyone got any other questions that they'd like to ask of Terry? Done them into silence.
Yeah.
Okay. So if no one's got any other questions, we'll finish up with this one. Oh, there's one. Janine, Norman, go ahead.
Hi, sorry, just coming in a bit late there, but I was just wondering how far you've been working with the council to, because obviously there is that sort of broader view around this, and they have sort of public health elements in their sort of remit as well, and just wondered how, didn't really hear much on the working with the council and that, and I just wondered if there was, what your experience was. And
yeah, they've taken up, Janine, the films. They've really embraced the films and using them in their own staff updates, which is really great to hear. Has public health, so we're absolutely involving them, and that will be me at an ICB level, involving the council leads actually, and that gets disseminated down. So a wider ICB strategic level, I get to update everybody, and then what they do with that is, how they operationalize it is up to them, but they've certainly heard it.
Thank you.
Brilliant. Well, thank you very much, everybody, for your questions, and thank you, Terry, for your time today and coming and talking to us about your work. We're really grateful. It's been a wonderful presentation. Just to finish up, we'll be sharing our webinars coming out on the coming week, our Placement Participation Week, which is starting on the 31st. And our next webinar will be at the end of July, and we will start getting dates out those to you really soon. So thank you so much, everybody, for joining us today. Lots of rounds of applause coming up there for you, Terry.
Thank you for having
me. We'll
me.
see you all soon. Thank you very much, everybody.
Thank you.